again for joining for today's session. Today we are planning to discuss a very important topic, that is communication skills. That is very essential for any course that we conduct. That is the most important topic that we conduct for all the training programs. And I think we had a few questions in the first session, like how to convince or how to talk to families going through life limiting illnesses, specifically to respiratory conditions. So today we have Dr. Biju Raghavan as our faculty. Dr. Biju is heading the Department of Palliative Medicine in Rajagiri Hospitals, which is in Alua. He is working in the field of palliative care for nearly 20 years now. He was associated with Pallium India since the beginning, and he's a faculty for many training programs in the country, including Indian Association of Palliative Care and many others happening inside the country. Um, and he's one of the best teachers also for many sessions. Thank you so much, Dr. Viju, for agreeing to take this session for this. So these are a group of pulmonologists. And this course is specifically for them. Like last year, you were a part of the same program last year. Welcome, Dr. Biju. Sir, can you hear me, sir? Rajlakshmi, I think Dr. Biju is unable to hear us.
I will call him in a while, ma'am.
Yeah.
Good evening, everybody. Thank you for this wonderful opportunity. I'm Dr. Deepthi. I'm a pulmonologist from Bhagwan Mahavir Hospital, Bangalore. We basically deal with all the pulmonary cases, and we also have a pulmonary rehabilitation unit set up. So we deal with all kinds of patient, and palliative care has been becoming an integral part of our treatment with patients. So today I'll be presenting an interesting case of a 66-year-old male who's a known case of COPD and has a chronic issue of severe breathlessness and type 2 respiratory failure being managed at home currently. Last presentation was around 2 weeks ago, where this gentleman came with worsening breathlessness from night and drowsiness from the previous night. What happened was this patient developed sudden worsening of breathlessness. Can you move on to the next slide, ma'am? Yeah, thank you. He presented with complaints of sudden worsening of breathlessness of MMRC grade 4 when he tried to get up from his bed to go to the washroom. What happened was he had a severe perspiration, chest discomfort associated with this, and had severe desaturation, and the saturation dropped to around 50s. It was not associated with either orthopnea or PAT. There was no other respiratory symptoms of cough or fever or chest pain. Following this severe desaturation, he became drowsy and had reduced response to his wife and children calling his name. They tried to insert a steroid tablet into his mouth because that's what had been told by the local doctor, and make him swallow, but that did not help his condition at all. They continued the oxygen supplementation, they reconnected the BiPAP mask to him, they gave him a nebulization, and with much difficulty, they lifted him off from his bed, put him in an ambulance, and got him to the emergency department. Next slide, please. He is already a known case of COPD since past 5 years, currently on nebulized medication. He's a known case of severe OSA since 5 years on home BiPAP. He's a chronic respiratory failure type 2, and he has moderate pulmonary hypertension for which he's been on long-term oxygen therapy. He's also had a bout of severe COVID pneumonia in 2020. Apart from the respiratory issues, he's a diabetic, a hypertensive, and a known IHT on multiple medications. Next slide. Thank you. Regarding his significant hospitalization history, almost since past 3 years, he's had more than 2 admissions every year. In year 2023, this current episode is his 5th admission, out of which 3 were in ICU. Each admission, pulmonary rehab team has been seeing him and trying to teach him breathing exercises. Apart from the regular nebulization, BiPAP, oxygen, and other antibiotic and medication, he's also been given a trial of fentanyl transdermal patch. Next one. Coming to his personal history, his diet, there is a fluid restriction component because of the IHT and the cor pulmonale and the pH status. Sleep has been disturbed lately due to breathlessness and discomfort. He also complains of constipation. Bladder habits are normal. Previous habits, he's been an ex-smoker with a 30-pack years behind him. He quit 5 years ago after the diagnosis of COPD. In examination, I'll just go over the salient features. The patient was drowsy and he was arousable, morbidly obese with a weight of 110 kg and a BMI of 40. He has grade 2 clubbing and bilateral pedal edema. Vitals, his saturation was dropping to around 60s in room air. And he was tachypnic on presentation. Respiratory examination, he had reduced chest movements and reduced intensity of breath sounds bilaterally. Other systems were fine. Significant investigation included a very high carbon dioxide levels of 94 mmHg. X-ray had shown bilateral hyperinflation. There was no infiltrates suggestive of any infection at this point. 2D echo showed cor pulmonale, moderate pH, and a normal ejection fraction. The rest reports were normal. So we admitted him to the ICU, started him on NIV, adequate dosage of nebulized bronchodilators, IV steroids, oral medications for bronchodilation was given, coverage of antibiotics was started. Once he settled there, he was shifted back to the ward with the BiPAP and oxygen support. Pulmonary rehabilitation team visited him again and personally breathing relaxing posture was taught. After discussing with the family, fentanyl transdermal patch was also applied. A written advanced care plan was given to the family this time and to the patient also, and he was explained. Coming to the most important aspects of this that I would like to have a discussion about, two things. One is the patient concerns regarding his health, and second is the family concern. The patient had a few concerns. He wants a medical options, that is, he is ready to go through anything, any tablets, any nebulizations, any BiPAP, any oxygen to reduce his COPD levels. Second thing, what issues he's been having about is his house has basically become a mini ICU with oxygen, BiPAP, nebulization. And because he's having multiple comorbid conditions, he's on almost 15 to 16 tablets per day. That's a very high pill burden. And this is an individual who has retired from a very high profile job, under whom there were around 250 people that he was managing and supervising. So now he is bedbound and he's become completely dependent on his wife and daughter for basic activities. That is frustrating him. He has basically no social life. He hasn't attended any of his functions, hasn't met any of his friends in the recent past. And now the financial burden is also pinching him with a long-time illness. Regarding family, the concerns are that his house is in first floor, so only wife is there, who is also elderly, by the way, who is round the clock taking care of him. Because he is morbidly obese, they're unable to mobilize him single-handedly. So each hospital visit is becoming a logistic nightmare. There is a feeling of helplessness because they feel that they are doing everything from their side. They're already giving him oxygen, BiPAP, nebulizations, IV medications are being arranged from home, tablets are being given on time. Despite everything, the disease is progressive in front of their eyes. And the family is currently in denial because there is no planning or discussion that has happened with the patient or with the family or with the doctors regarding what to do if the patient requires a ventilator. Does he want to go into ventilator and intubation? Is a resuscitation plan in place? And what about long-term nursing care? Next one. Next. The barrier that is being faced by us as a treating team is apart from his breathlessness due to COPD, the morbid opacity and the OSA itself is compounding our problems to treat him adequately. We are treating him adequately medically with all the medication, but the feeling of breathlessness, we are unable to treat to this patient. And second thing is the patient is a bit resistant to other modes of treatment, such as breathing exercises and rehab exercises. and we are unable to get through to the patient as well as to the family regarding the prognosis of the patient as well as the need to sit down and have a plan. Next slide, please. Next slide. Thank you. So the things I want to discuss with the faculty available here regarding how do we convince these kind of patients who are very knowledgeable, up to date with every medical aspect possible regarding the disease as well as the treatment, to just sit them down and make them learn few basic exercises and regarding what to do when such a exacerbation happen at home and what all can be included in a proforma that can be given to the patient as advanced care plan at home. Next thing I would like to know is how do we get through to the patient and the family as a whole regarding how to start a conversation about how to go about if the prognosis is negatively impacting them in the future, how to start that conversation, and how not to lose hope in such patients as a caregiver for us, like as a team, because we also feel that we are doing everything from our side and we see the patient deteriorating every admission. And last but not the least, I would like to know the benefit of fentanyl transdermal patch in these kind of cases. Thank you.
Thank you, Dr. Deepthi, for the presentation. I think um, shall we just go through the session and take this last slide again after the
Yes.
end of the session and see
Sure,
whether
sure.
we
Because the
have
topic
touched upon
itself
all
is
the points.
communication. Yes.
Yeah. So whether we have touched upon all the points, whether we have left with anything unanswered, and then is that okay to go like that?
Yes, yes, definitely.
Thank you so much.
Thank
Dr.
you.
Biju, I hope you are able to hear us now and your problem is fixed with the audio.
Yes, Sridevi, I can. I'm sorry, there was a bit of a glitch at my end.
Over to you, sir. We'll take up this discussion point slide towards the end once again. Whichever points we have not answered maybe can be taken.
Right. So I don't know the format of the this program for pulmonologists. Are they also getting some kind of sessions on symptom management?
Yes, sir. Yes, specifically on pain, breathlessness, and some symptoms associated with chronic respiratory illness.
So I guess it will also cover refractory breathlessness.
Yes, sir. Chronic breathlessness syndrome was taken last week. That was covered last.
No, the use of opioids and benzodiazepines, etc.
Yes, yes.
In refractory, has those sessions been taken?
Yes, last week Dr. Miriam Johnson spoke about it.
Right. So anyway, today we are not going there because we are going to talk about communication issues, and that too we'll be doing it in two parts. Today we'll be doing the very basics of it. So we'll not be going specific into areas of how to communicate bad news and those kind. That will be next week on 11th. So today we're just going to see a little bit of the basics. I will share the screen and we'll take it from there. I hope you can see.
Yes, sir. Good to go.
Right. So basically, I'll start off with this study, a very old study which came in the headache journal. And what they said was the best predictor for resolution of headache turned out to be the patient's perception that they had an opportunity to tell their story and discuss their concerns about their headache fully with their physician during the first visit. So usually we consider communication skills as some kind of an add-on bonus that we give to our patients and families. And what we need to understand that communication skills actually can make a positive outcome in the clinical outcome. So therefore, we learn communication skills to enhance our clinical effectiveness, because that is what, as doctors, that is what we are aiming at. A lot of medical errors can be taken care of because of communication errors. Many a times, the allegation, the usual allegation in the media is, or among the among people in society is that the doctor gave some wrong medicines or some wrong injections or wrong dose and things like that. So a lot of communication on when we prescribe, we also tell them what these medicines are for, how it should be taken. I'm sure all of that thing is being done, but is the message getting across? So that is also an issue. And as a result, the doctor patient relationship is not great at the moment. We are always afraid that somebody might sue us, or even worse, physically assault us. There's a lot of suspicion among the society, among the community, about the intentions, and a lot of the mistrust about medical professionals. So there's a big divide growing between the medical professionals and society at large. And doctor patient relationship, which I also include the family in it, is a complex web. And just like we were taught that the basis of any diagnosis is good history, history taking is nothing but communication skills. And however, we are taught uh, by rote of how to take a history. A presenting complaint, history of presenting complaint, past history, family history, etc., etc. And we learn it in a mechanical manner because that is how we have been taught. And that is not usually the way we human beings interact with each other. So therefore, sometimes diagnostic accuracy can be missed for lack of inadequate communication. And you may find the right pathology, but until and unless you understand the patient's personal beliefs, their financial issues, their other logistical problems, the social setup, so your best management may not be may not work because they may not be practical. So we good communication skills will help us tailor make the management for the patient, and only that what is practical will get done. So if we want to get clinical outcomes, we have to think in terms of what is practical, and probably the best option may not be the practical one. So better diagnosis and better clinical outcome depends on better communication skills. In that sense, we should learn communication skills for our own selfish interest, because it helps us uh, get better outcomes. It should also get better patient compliance. Many a times what happens is you give a prescription, the patient takes his prescription to the medical shop and then asks the medical shop person whether I should take this medicine or not, prescribed by the doctor. And the and the person in the medical shop, the only call that person may not be even the pharmacist. The pharmacist may be somewhere else, and the only qualification of this person in the medical shop is he or she may know where the medicines are in the shop, and that person will sit in judgment over your prescription. The learned doctor that you are, your prescription will be judged, and the person at the shop might say, oh, this medicine is hot, this medicine is cold, or there is a better alternative, based on what suits them financially. So many times all of these things happens. In short, patient population would rather believe uh, somebody else, the pharmacist, or the some other stream of medicine, alternative medicine practitioners, or any mumbo jumbo, because somewhere the we are falling short of earning the trust, and therefore the compliance goes down. And if the compliance goes down, the outcome goes down. So better communication skills will ensure better compliance, and better compliance will get better outcome, and better outcome will give us a happy patient and family, a satisfied patient and family. If your patient and family, or most of your patient and family, are happy and satisfied, it will reduce our stress, it will reduce the stress of our team. So better satisfaction of the team and you as an individual. So that is also our own selfish interest. Along with it, our safety. Good communication skills should protect us. It should protect us from physical harm. It should protect us from emotional harm. It should protect us from financial harm. And therefore, good communication skills we learn for that selfish interest. Therefore, basically, good communication skills should work in our favor. Of course, it helps the patient and family, no doubt about it. Probably it will create some goodwill in the society, but that is not the reason we are advocating better communication skills. We are advocating better communication skills because it should save us time, energy, effort. It should get us better clinical outcome, and it should protect us better. That should be the indications of learning communication skills. So, communications skills is essentially relationship building with our patient and family and the patient and family cohort that we are dealing with. Because if we build good relationship, that will any day protect you more than the consent signatures you will take on a piece of paper, which in a court of law is highly unlikely to protect you. But good relationships will definitely protect you, uh, not 100%, but it will improve your protection, it will improve your compliance, it will improve everything. And all of this should work in our favor. So that is what the essence of good, the reason why we should have better communication skills is because it will help us build better relationship. And the basic foundation of good communication skills is active listening. Active listening is as opposed to passive listening. It is not, definitely not just sitting and listening. It's a much dynamic process. A lot of things go into it. So today's session will be on active listening, and for convenience I have just divided it into two parts. One is the body language and second part is the verbal do's and don'ts. The question comes, why we doctors should learn body language? Because we as doctors, we are also human beings, and like most human beings, we are often not aware of how our body is communicating, because most of the time we are focused on the subject matter we are trying to communicate, the medical information that we are trying to get across, and many a times we may not be aware of how our body is communicating. And many a times it is possible that what we are saying verbally may be in conflict with what our body is conveying. And apart from that, we may be also giving some negative vibes with our body. So, therefore, being aware of our own body and what messages our body is conveying will help. Another reason why we should learn body language is because the major component of any communication, interpersonal communication, professional communication, any communication, the major component is non-verbal. It is body language, and this is across language, culture, geographical uh, variations, race variation, across the board. The major form of communication is non-verbal communication. It is the body language which enables us to help uh, communicate with our pet dog or cat. So it is something that we have to understand. We not only communicate among ourselves, among human beings, we also communicate with non-human entities also through body language. So it is the major component of body language. Therefore, it is important to be aware and learn a little bit of body language. Now, obviously, in today's session, I will not be able to cover anything significant on it, but feel free to Google for body language for doctors. You will have plenty of material. It is, you can spend a lifetime on learning body language. Will still never finish it. There is that much information available, and nothing is going to be a waste of time, energy, or effort. That I can assure you. For today's session, I have just put up 6 or 7 points, which I will, you know, uh, talk about. First and foremost, any relationship starts with eye contact. Therefore, when a patient comes into your OP, take your eyes away from the computer screen or the case sheet in front of you and make eye contact. When you go into a patient's room as an IP round, take your eyes away from the case sheet or talking to your colleagues and straight away focus making eye contact with the patient and the family members over there. And it is very important that you make eye contact because that is the starting of relationship every time you meet a person. Apart from that, smile. Smile is universally acknowledged as a positive uh, positive language, sign body language. However, we human beings are designed to smile at somebody we know and we like. We are unlikely to smile at people whom we don't know or we don't like. Therefore, a professional smile is something that does not come naturally. You have to practice it. It is a skill, just like how you know, a skill, for example, how to check BP. Somebody taught you how to check BP in your MBBS first year physiology lab. Somebody taught you, then you practiced and you got good at it. It's just like any skill, but it will not come until and unless you practice it. Therefore, to practice it, the safe environment for each one of us is our work environment, hospital. So plan, consciously plan that today I'll go and smile at the security guard. I'll go and smile at the cleaning staff, FNB staff, the office staff, the clerical staff. I will smile at my colleagues, the nurses, the physiotherapist, the pharmacist. I will smile at everybody. And sometimes you may get a stare of confusion, but don't worry, you are not doing this to butter up people. You are doing this to acquire a skill called professional smile. Practice it so much that at some point of time you don't have to think about it. It will come like a spinal reflex. Anything resembling a human face passes in front of you, a smile will come, and it will be effortless. Now, this professional smile will get you out of trouble situations also. It will also help smoothen out any rough edges in any relationship with any of your patients and families, especially when we are dealing with complex medical conditions and not and grave prognosis. So that doesn't mean you smile all the time, but at least the beginning of any interaction, when you bring in a smile, it calms down the environment. Another advantage of learning this professional smile, practicing it, is that it will get you a good tone of voice totally free. You don't have to practice because it is impossible to have a bad tone of voice with a smiling face. With a smiling face, you'll always have a good, warm, welcoming tone of voice. With a grumpy face, you get a grumpy voice. With a happy face, you get a happy voice. And why it is important? Because many a times we get into problem not because of what we said, we get into problems because of how we said, the tone of the voice, the pitch of the voice, the volume of the voice. Anything can trigger a negative reaction in a person who is recipient of our voice. Therefore, with a smiley face, you will have a good voice and a lot of trouble can be avoided and you can get out of a lot of trouble and you can build good relationship very fast, effortlessly with such small things. Another area of importance is how you position yourself, and that has a bearing on the satisfaction level. For example, on the left upper side of the picture, you are seeing a healthcare professional standing by the bedside of the person. And you notice that this person is standing nearer to the head end of the patient. As a result, the patient is making eye contact and the health professional is making eye contact. It is comfortable for the healthcare professional, but you see the sternocleidomastoid of this patient, how prominent it is, because this patient has to look at the healthcare professional at an acute angle, and uh, beyond some time, it is going to be uncomfortable. Therefore, when you enter a room, if you position yourself near to the foot end of the patient, the initial part, hello, how are you, how are things, so the initial inquiry and those kind of things you can do by standing near the foot end of the patient, because then the patient can make eye contact with you comfortably without straining at the neck. And once you have done all the inquiry, then you can move in closer for your examination, physical examination, etc. On the right upper picture, you see a healthcare professional sitting by the bedside of the patient near the foot end. So the patient can make eye contact comfortably with the patient, doesn't have to turn the neck a lot. So that is the difference. Another difference is this healthcare professional is standing and making eye contact. Therefore, the eye contact is not level, it is looking down from above. And that creates hierarchy that will uh, be less appreciated than when you bring yourself down so that the eye contact is at level. So when you bring your eye contact at level with the patient, for example, if the patient is standing and you keep sitting and you look up, that also is creating hierarchy. If the patient is sitting or lying on the bed and you stand, that also creates hierarchy. So if there is somebody standing and you don't have a chair to offer, if you also stand up, that creates equality. If somebody is sitting or lying down, you pull up a chair, that also creates equality. And this enhances satisfaction. I'll give you an example. If guests come into your house, they come and they position themselves in your drawing room, have a conversation. You offer them tea, they have tea. You offer them snacks, they have snacks. But during all this time, they never sit down. They continue to do all of that while standing. Would you be satisfied? I doubt. Whereas if they come and sit even for 5 minutes, that is satisfactory. Therefore, it is important to understand that when we have patients coming into our consultation room, offering a chair for the patient and family increases satisfaction. When we visit them in their IP rooms, we sitting down, pulling up a chair or a stool anywhere and bring our eye contact at level rather than hierarchy. So that also improves satisfaction. When it comes to children, we as adults are big. Therefore, when a child is standing, sitting, or on the bed, we have a tendency to bend at the hip and literally look from above. And that often scares children. They may get afraid, they may start crying. Whereas if you pull up a chair, or if your knees don't hurt, like this gentleman bend at the knee, making your eye contact at level, this will be less scary, less intimidating for children, and they will also be able to cooperate with you. So for adult, it increases satisfaction. For children, it increases confidence, it reduces the fear of you. So how you position your body in relationship to your patient's body or the family member's body can either increase satisfaction or decrease satisfaction. So all of this also goes on to building up relationships and trust. Another thing to consider is body posture. If you see this person in lordosis and this person in a slight kyphosis, this is usually the position we adopt when we are sitting for our external examiner viva. And this is sometimes the posture of the big consultant in his or her consultation room. So if you don't check yourself, many a times we may be sitting in lordosis, and lordosis is going to be unsatisfactory for your patient and family, and sitting with a little bit of kyphosis is going to be satisfactory. Why? Because when you sit like this, your body is conveying, I'm here to listen to you. I want to know your story. I want to hear what you have to say. Whereas this Laodicea conveys, I'm the Lord and Master of my universe. I don't care. I'm an arrogant fellow. So even if you don't mean it, unknowingly, if you are, this is a bit of a caricature, but these are the ways we can interact with our patients and families. You don't have to bend forward like the Air India Maharaja's pose, but a little bit of kyphosis goes a long way in improving satisfaction. So till now we have talked about eye contact, smile, tone of voice, body positioning. As much as possible, level your eye contact with your patient instead of looking from above or below, and little bit of kyphosis. All of these things improve satisfaction, and that is what we are aiming for, improving satisfaction. Apart from that, we also understand that we all have our space. That is why when we are driving, if somebody suddenly overtakes us and comes into our space in the road, and we have to slam our brake, we usually end up saying some unparliamentary words in our car. So it happens because our body space, we feel our body space has been violated, even though the road belongs to everybody. So body space is a reality, and we feel the problem when we are in a lift with strangers, we feel uncomfortable. However, we are very comfortable with whom we are intimate, our family members, our children, our spouses, or our close friends, close relatives. So when we are with them, we stand very close to them, even skin to skin touching, because that is how we are with intimate people. Maybe our children, our spouse, we may just put our hands around their shoulder, anything. With our colleagues or with whom we meet regularly, but we are not intimate, we adopt a social distance, which is probably within 1 meter radius. Within that, then there is the other people that we don't know, and we try to keep a little bit more of a distance. That's the public space. So intimate space, social space, and public space. However, in our profession, the patient and the family members, when they come to us, they are nobody of ours. But because of the profession we are in, we have to intrude into their personal space. We have to examine them, auscultate them, palpate them, percuss them, or and maybe other procedures. So all of this creates discomfort to the patient, and it creates an emotional trauma because it is in a way violation of their space. And even though you may say they came to us, therefore there is an implied consent. And I would agree, there is an implied consent. So rationally, it is fine, but emotionally, it is still uncomfortable. And therefore, whenever you have to uh, touch a patient, you tell them that you are going to do that. For example, if you want to auscultate, you tell, I'm going to examine you and show the chest piece before you actually put the chest piece on the person. If you want to palpate, you tell them, I'm going to examine you, and then tell them. If you're going to do a procedure, then tell them that this is the procedure. And while you're doing the procedure, uh, assuming it is not something that uh, being done under general anesthesia, so assuming that the patient is lucid and able to comprehend everything, and you can do a running commentary so that they are mentally prepared for every step that you're going to do. For example, in my case, when I have to put in a Foley's catheter to drain urine, I tell them that this is what is to be done. Then when I get this person to lie down and position, when I tell them I'm going to clean your area with a liquid, and it might feel a little cold, and then I apply uh, the antiseptic solution. Then I tell them I'm going to put a cloth on them. Then I put a cloth. Then when I'm giving the lignocaine gel into the urethra, assuming it's a male catheterization, then I tell them I'm going to do this, only then inject it. And so on and so forth. So basically, you reduce the startle or reduce the anxious moments for the patient, because in any case patients don't come to us because they want to come to us. They come to us because they are sick, they are not ill, they are not well, they are suffering. The starting point itself is negative. So patient and family will already be anxious, worried, maybe irritated, frustrated, or a combination of any of them. So when you are touching them, when you give them a head start by letting them know that this is what you're going to do, then it will reduce their anxiety, reduce the startle moments, and overall increase the satisfaction. So here there's a picture of this healthcare professional, a well-meaning gentleman, but the body language has startled this patient, and look at how much he's leaning back into the backrest of the chair. And so this is something that we want to avoid. And this happens to be my palliative head nurse, who this is pre-COVID home care team. And look at this picture. This is everything that we have talked about so far. Eye contact, and then you have smile, and with this smile, I can guarantee that the tone of the voice would have been warm and conducive. And look at the body position, both are in the sitting position, and therefore the eye contact is level. It is not looking down or looking up. Eye contact is level. This is creating equality. And then there's a slight kyphosis at the neck level. You don't have to have a kyphosis of the entire body. That will be a bit of a caricature. There's a slight kyphosis here, there's a slight kyphosis here. That is good enough. And then you have body space, comfortable body space. So both people are very comfortable, right? So this is what we should be aiming at. And don't forget the human touch. This is not about physical examination or touching the person for any procedure, endoscopy, bronchoscopy, nothing like that. I'm just talking when somebody is distressed, a touch. So I make it a practice that when somebody comes into my OP, and after all the consultation is over, when they're about to go, I just extend my hand and give a handshake. And oftentimes I see that when I extend, their people's eyes light up, their faces light up, they have a smile on their face. No matter what the discussion was, the discussion could have been very traumatic, but in the end, when you give a hand and you shake hand with that person, the whole atmosphere changes. The same thing I do when I go for IP, and after all that round is over, before leaving the room, I give a handshake. Sometimes when I'm communicating something sad or something bad, and the patient or the family member is emotional, sometimes I may touch somebody on the shoulder, like my social worker over here has put arms around. So all of these gestures goes a long way in creating the sense of empathy, that this doctor means well, this doctor cares about us, this doctor listens to us. And this is all about not spending more time, but what you do with the time that you anyway spend with the patient, either in the OP or in the IP round. When you incorporate these measures in your body language, all of this adds up. You don't spend additional amount of time, but within this time, you just add all these elements. It enhances the experience of the patient of interacting with you. The next area that we are going into is the verbal do's and don'ts. Your breathlessness is better today, isn't it? When you ask a question like that, it may be very difficult for a patient to say, no, I'm not good at all. An empowered patient may be able to say, but somebody who is socially from a background who is disempowered, financially disempowered, or just plain scared of you, or the system, or the big hospital, everything. So, such patients may not be able to. Therefore, if you want the right answer and the correct information, ask a simple, open ended question: how are you? How are you today? And you will get the answer. So never ask a leading question in a leading tone. Always ask an open-ended question in an open-ended tone. You're feeling better, isn't it? Instead of that, ask, how are you? And that you will get the answer. Because remember, information is power, but only the right information is power. If you have the wrong information, it can be disastrous because your management strategy can totally go the wrong way if you have wrong information. If I have a toothache and you say, oh, it is only that, I will not like you. Because for each person, their problem is the biggest problem. So never minimize anybody's problem. And if you say, oh, you have a toothache, look at the pediatric ward in the regional cancer center, and then you will see what real misery is. I don't care if there are some children in pediatric ward in the RCC suffering. My toothache is the biggest problem. I don't like if you compare my problem and try to minimize my problem, showing somebody else's suffering, because I am suffering. The reason is that we are all egocentric. For us, our problem is the bigger problem. For us, our problem is the only problem. So when, even despite, with good intention, if you try to minimize my problem, with good intention you try to compare my problem with somebody else who has a bigger problem than me, this is not going to help. In fact, it will only make the relationship bad. I will feel you don't care, and I might end up hating you. Instead of that, if you just say, oh, this must be terrible, I said, okay, somebody understands me. At least there is this doctor who is not dismissing me. And if because of this toothache I've been jumping around and making a scene, and if you tell me, anybody in your position would have perhaps behaved like this, then basically what you're doing, you're normalizing my emotional experience of this pain. Remember, you're not normalizing my pain, you're not normalizing my problem, you're not normalizing my symptom, you're normalizing my emotional experience of the symptom. And when you make statements like that, you create positive energy, you create trust, you create this feeling that I see you, i I am empathetic towards you. So these are the words that we must bring into our vocabulary when we are interacting with our patients, instead of minimizing or comparing. uh, Giving false hopes, sometimes we ourselves are so, sometimes feels helpless, that we may give a cliche answer: don't worry, we are there, pray, and everything will be all right. You are being tested, God is testing you, all that kind of things. So always give hope, but make sure you give realistic hope. In my day-to-day practice, at least uh, 2 to 3 cases where I have to say on a daily basis that your disease is fairly advanced, and probably nothing much can be done about it. But I'll make sure you don't suffer, and you can come to me as long as you want. And when I say statements like that, I am telling them the truth, but at the same time, I am giving them hope that even if your disease cannot be cured, I will ensure that you do not suffer. And I'm always available to you. You can always come back to me. So basically, the message is that the suffering will be taken care of. Secondly, you will not be abandoned. There'll never be a situation where I have to say nothing more from my side. And that perhaps I have an unfair advantage, uh, since I'm practicing palliative medicine. So many a times we start where the curative practitioners stop. So therefore, it's an unfair advantage. But you are always welcome to learn the principles and practices and strategies of palliative medicine and incorporate into your practice as pulmonologist. And there will never come a time when you have to say nothing more from my side, irrespective of the stage of the disease. So always give hope, but never give false hopes. Always give realistic hope. And just to let you know that when I say things like that, oftentimes the response that I get is, "Doctor, that is all that we wanted to hear." Or they may say, "Doctor, now I am feeling hopeful. Now I am feeling strength. Now I am feeling courage." So various kind of responses I get, but all the time these are positive responses. So give hope, but make sure you are giving realistic hope. It comes with practice. It doesn't come easy, but that is what we are here to learn. And another area of importance is never assume when people say something. For example, you ask somebody, "Is your breathlessness better?" "Yeah, much better. I'm feeling much better." And then you ask the next question, "Do you have satisfactory relief?" Then probably that person may say, "No, I am little bit, but not really." So basically, when we are talking about providing comfort, the one thing that we always have to ask is, do you have satisfactory relief? Because whichever symptomatology we are targeting, we have to, the goal should be satisfactory relief for the patient. It is not reducing the symptom, it is always providing satisfactory relief. So when you ask this question, then you will get the answer. Then you will know whether you have achieved the target or not. If yes, great. If not, you need to work more on it. There are other areas of do not assume, but that we will talk about in the next session when we talk about communicating bad news. So more complex areas, more important than we do not assume. A short history taking, of course, we are all experts in taking history, but taking into consideration all the body language and the do's and don'ts, just incorporating that into history taking. So therefore, history taking 2.0. And whenever a patient comes into your OP or you go into patient's room for your rounds, the first point is greeting. The first top part is greeting, and it constitutes making eye contact, smile. No matter how bad the situation is for your patient, always start with a smile and then say something that is culturally appropriate. If it is culturally appropriate not to say anything, that is also fine. And the next step is get comfortable. If people have come into your OP, make them comfortable. Give them seats, places to sit down. In my OP, apart from the customary patient's chair and two bystander chair, I have also requested the management to provide me a couple of plastic chairs which I can stack up on top of each other, so that in case there are more people can sit. I prefer nobody stands in my OP, because then everybody feels that they have been treated with respect and equality, and it helps building relationships. If you have gone to a patient's IP room, pull up a chair, pull up a stool, just sit somewhere, and because that enhances satisfaction, it builds a relationship. Then when you start the interview, always start with an open-ended question. If OP, okay, tell me what brings you here, or just tell me, simple. Or if you have gone to the IP, you can ask, how are you today? And then listen, do not interrupt. A lot of studies on this part have come up, and not surprising it is, but such a shame that they have found that doctors interrupt the patients within 15 seconds of their patients opening their mouth. And therefore we have to remind ourselves, even though I teach communication skills, I still have to remind myself, just shut up and listen, 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 listen. And Dr. Rajgopal sir, who taught me palliative medicine, in his OP room there is usually a small plaque written with listen on it, and it faces him directly so that he can look at it whenever he's looking at a patient. So it is something that we have to keep on reminding ourselves, because it is so easy to interrupt people when they start talking. Not only is it not important to not interrupt, it is also important to encourage the patient to talk. And for this, make eye contact. Making eye contact does not mean staring at them. Make eye contact like normal conversation. And along with it, nod your head from time to time, and make some encouraging sounds, or say something or ask something. So, like, okay, then what happened? Okay, then go on. So these kind of encouraging sounds from time to time you have to give, so that the patient knows that he has permission to speak. While the patient is telling you, patient and family sometimes together tell you their problems, clarify. If you did not understand something, you clarify then and there. Don't wait for I will ask later, because we don't know where we'll end up later. And this is all the more important when we are dealing with complex medical condition, not simple cough and cold. When we are dealing with complex medical condition, that a lot of disease related suffering, then we need to clarify as we go along. Along with it is also important to understand what do they understand about their medical condition. So questions like, what did the doctor there tell you? Surprisingly, or maybe not, many times when I ask them, they have no clue. And I asked them, which doctor you went and saw in that other hospital. They have no clue what specialty the doctor was there. Forget about knowing the name. So I would suggest we should do a bit of marketing for ourselves whenever we see patients. Make sure that you mention your name, and also tell them your profession, especially when you go for consultations in the IP. And because then they will have better information, they will be able to understand what is going on. But unfortunately, most of the time, they have no idea. You can ask them, what did the doctor tell you, what did the scan report tell you, what did the blood test tell you, etc., etc. And many times we'll realize that they have some correct information, some wrong information, and a lot of no information, lot of blank spots. They have no idea what is going on. It's also important to understand what their concerns are. It could be financial concerns, it could be some belief related concerns, it could be logistical problems. For example, you are suggesting admission, but there is nobody to come and stay, because if the only person who can come and stay is the only person who's got a job, and if that person comes and stays, then there is no money coming in. And obviously the hospital will not allow the patient to stay alone in IP. So there could be logistical problems that could be a concern, financial problems could be a concern, beliefs may be a concerns. And once you have all the information, maybe a time will come where you have to discuss the medical things and just give information, and therefore give information in a language that they understand. For example, if you say USG of the abdomen shows a cyst in the ovary, nothing to worry about. Now, you and me understand this because it is Greek and Latin, and we understand it because our medical education was Greek and Latin. But for the person sitting in front of you, it sounds like Greek and Latin because it doesn't make any sense. Maybe it will also create a lot of complication because the patient says, oh, they did the wrong test. I paid money for a scan of my stomach, and they did some test called USG. And now they are telling me that there is a cyst in the liver. Cyst means cancer. And they are saying nothing to worry about. So instead of that, if you could just say the scan reports have come, it shows some swelling around the ovary, and by the look of it, it does not seem to be anything to worry about. So instead of USG shows cyst in the ovary, nothing to worry about. If you just say the scan reports show there's a slight swelling around the ovary, but does not look like anything serious, and we will follow it up. You come after 1 month, and we'll again have a look. So simple language gets the message across, and it will reduce confusion and also friction. When we have to discuss about treatment options with our patients, now again, there is an issue. We are comfortable uh, conducting a medical board, tumor board, all of these things we are comfortable. We are comfortable doing cross consultations with other colleagues of other specialities. We are comfortable discussing with colleagues in our own specialty. We are all comfortable with it. But many a times we are not comfortable, or we don't think it is important to sit with the patient and family and discuss how, what are the treatment options. The reason why I'm saying that is, you may have an expertise in pulmonology, you may take an opinion from the cardiologist, you may have a medical board, etc., etc. But the patient's life, the only expert about that is the patient and the family. So when we are talking about management, we may be having the best option. But if we sit with the patient and family and discuss it, then they will tell you the problems, their concerns, their worries. And based on that, we may be able to modify the management to that which is most practical. And that practical will get done. The best management option may not get done, either due to financial issues or logistical issues or belief issues or whatever. Basically, if you want to get outcome, you need to have a management strategy which is practical. Therefore, including the patient and family at some stage and sitting with them and building up a consensus on the management is going to help us, because then we are not imposing a treatment on them. We are discussing, and together we are choosing together, patient, family, and the medical system together we are choosing. So therefore, we are equal participants in choosing what management strategy. Therefore, if something goes wrong, as often it happens in medical practice, at least we are not the only guys who are going to be blamed, because we discussed all of that together. So decision by consensus is practical. Decision by consensus is also protective. I'm not guaranteeing 100% protection, but definitely it is protective. So participatory decision by consensus is something that we should aim for. This is something that often is not we see, because there is no mentorship in this kind of decision making, but it is something that in palliative care we do as a matter of fact. Then once the interview is over, we summarize and we confirm the plan. Then we tell, okay, you come after 2 weeks and things like that. And in the end, always ask, after all the discussion, always ask, is there anything else? Is there anything else? Is there anything else that you want to say? Is there anything else that you want to ask? The reason why I suggest we do it is like this. When you have a sumptuous meal and you are totally satisfied, but in the end, if you don't get the dessert, you may still feel that it was not complete. Whereas if you had even had a normal meal, at the end, if you get something sweet, you feel happy, you feel everything, that you had a complete meal. So this last part, asking in the end, is there anything else that you have to say or you want to ask, will bring a smile on the faces of your patients and families. And they will often say, no, doctor, thank you. And it is with that smile that you should leave the patient's IP room, or your patient and family should leave your OP consultation room. So that is the most important part in the closing part of the interview. You give them the dessert, the sweetness, by asking them this question. The last part is that leaving the door open. That means even though we have agreed that we'll meet after 2 weeks or 1 month, in case you need to come earlier, feel free to come. Now, I discovered it firsthand during my home care visits, that if there is a acute problem and I have discovered this, and I suggest to them, the patient and family in their home, when I visited them at their home during home care, I tell them, why don't you go to the hospital and consult your doctor about this? And oftentimes I hear them say, but the doctor asked us to come after 2 weeks. So how can we go now? Now, initially I thought it was one off, but the more I saw this, I realized that most people really don't know what seems like common sense to us in the medical profession. Outside the medical profession, they really think that you're not supposed to go after that time, especially the less empowered segment. They don't know. And when I ask them, of course you can go, they say, oh, can we? So it is important that we tell them verbally. And in my practice, I've also started putting it in my prescription. For example, review after 2 weeks, report early if needed. Report early if needed. So that I tell them verbally, I also put it in the prescription, and I made a practice of it. So it is like leaving the door open while you are closing the interview. And in the end, you also, provide greeting, you make eye contact, smile, nod your head, and say what is culturally appropriate. Or if saying nothing is also culturally appropriate, that is do, but do make eye contact, smile, and nod your head. So to finish off today's session, the take-home message is all that we learned today as part of active listening is creating an experience of empathy for the patient and family. We don't care about what is the definition of empathy, what is empathy, sympathy. That is all theory. In real life, real practice, they should remember you based on how you made them feel. And oftentimes, that is what they remember. They may not remember the degrees behind your name or the flashy, 5-star hotel or the hospital that they visited or the crores of machinery in the hospital. They may not remember any of that, but they will definitely remember of how you made them feel. And if you made them feel that they are wanted, they have been listened to, we care for them, then they will never leave you. They'll keep coming back to you. And if the experience is the opposite, then they will go and tell the whole world that these people are not good. So negative publicity can be harmful for business, and good publicity is always good for business. So practice positive body language, remember the verbal do's and don'ts, and make sure that you have given them the experience of empathy always. So with that, I'll stop here. I'll stop screen sharing. I'll be happy to take questions. Thank you.
Thank you so much, sir. We'll wait for a few minutes if there are any questions from the participants. Either you can unmute or you can type it in the chat.
Questions as well as experiences are both
Yes,
welcome.
yeah. Any comments or anything that you have faced during your clinical practice, would be happy to.
We just covered the basics today purposefully because when we go to the advanced areas of communicating bad news, how to deal with collusion, how to deal with anger, the things that we learned today will be the foundation on which we will be building up other communication related expertise.
Sir, there is a question on consent. Consent in palliative care.
What exactly is the question?
The constituents of consent is what he has asked, Dr. Suresh Kumar. Please explain the key constituents of a consent in palliative care.
I have no idea what this question is about. For example, I don't know whether the answer I'm giving is relevant or in the context of the question. One area that we do take consent is on end of life care, because when we are taking care of terminally ill patients, we want to protect them from critical care. So we do counseling session for the patient or the family. Many times we may not have consent to talk about this to the patient, but definitely with the family, and sometimes where possible with the patient. So we tell them about this end of life care and protecting the patient from critical care. So as part of it, we have a document, basically DNR. In some places we call it DNR. In some places, because of the accreditation related issues, we are uh, not supposed to use DNR. So I don't know. It doesn't make sense, but for some reason we are not supposed to use the word DNR based on because of accreditation issues. Don't ask me why. I mean, so therefore, at least in our hospital, we instead of DNR, we use the word end of life care. So after counseling the family, we get the consent. So we also so this consent is taken either in the ER or in the ICU before shifting the patient uh, to the wards.
Sir, I
So
think the
that is
question was, sorry.
yeah. So I don't. So that is. I don't know. That's what I'm saying. I have no idea about what was this
Yes.
question about.
Sir has explained once again in the chat. I want to know what should be included while taking consent for providing palliative care by a physician. So, for providing palliative care, if you are integrating palliative care into some other specialty, would you take a consent for
No,
just for
no,
providing?
no, not really, not really. Because see, in my hospital, I am providing uh, comfort care. If you remove the word palliative and instead of that, replace it with the word comfort care or supportive care. So, so a lot of confusion can be taken care of. So I'm providing my services to mm, more than 20 departments, from dermatology to neurosurgery. So providing post-op pain management, various kinds of pain relief services, also breathlessness services to the pulmonology department, cardiology department, etc. And providing comfort care for patients with curable medical conditions, irrespective of speciality or the diagnosis or the stage of disease. We're also providing comfort care for chronic medical conditions. And, like COPD, interstitial lung disease, are familiar issues for in pulmonology. We're also providing comfort care for terminally ill patients. So the same comfort care, the same principles and practices that we are providing is provided for patients with curable medical conditions so that they can have their curable treatment comfortably. So the disease treating doctors can focus on diagnosis and treatment, whereas we take away the headache of their headache off their head of keeping their patients comfortable, counseling them, keeping them motivated, responding to their queries. And it is not that when we give answers to the queries, we are giving something off our head. We'll always consult with the treating consultant and ask them. So these are the things that they have come up with, and based on that we do. So we also save time of our consultants in other specialty, be it pulmonology, oncology, neurology, dermatology, plastic surgery, nephrology, cardiology, all kinds of places. So palliative care is providing comfort not only to the patient and family, it's also providing comfort to the consultants of other specialty. So it's a win-win for everybody, and no consent is required. If you, as a pulmonologist, want to avail of palliative care services, you can just send a cross consultation on whatever stationery is available in your hospital, and that is all that is required. What I meant was for the DNR consent, or as we call in Rajgiri Hospital as end of life care consent, that is required because otherwise the nurses will be forced to call for a code blue. So therefore, that is why I mentioned about DNR consent or the end of life care consent.
Sir, there is another chat from Dr. Shahjahan. Sorry, that was from Shahbaz. Limited time and lack of facilities in a government setup are barriers to at least some components of the communication, I think. So it's not a question, just a comment from Dr. Shahbaz.
Yeah, most of the time when we have this topic, most of the doctors, most of the time, do bring up the lack of time issue. So I have two things to say on that. Good communication skills is supposed to save you time, energy, effort, get you better clinical outcomes, and protect you. If the communication skills are not doing that, then that is not good communication skills. And the first thing about good communication skills is it should save you time, energy, effort, better outcome, and safety. These five components is what makes good communication. If that is not happening, then we simply have to improve our communication skills. The second thing that I want to bring to all of you is that communication skills is a team sport. It is not one person's burden to carry. It is not something that you're providing as bonus to one patient or family. It is for our own survival, for our own well-being. Therefore, everybody in the healthcare system, from the person at the security gate, the security guard at the security gate, till the CEO of your institution, the top man or the top lady, everybody across the board needs to be trained in good communication skills. There may be some variations you can provide. For example, as doctor, so this session that we did today, this could be given universally to everybody in the healthcare system. The security people, the FNB people, the operations people, the admin people, the management people, uh, our paramedical support system, physiotherapists, pharmacists, clinical psychologists, you name it, everybody. Then doctors, nurses, everybody. So today's session is something universal for everybody in the healthcare system. Then you can have specialized sessions. For example, the next session we'll be doing on part 2, that will be for doctors. That is not designed for nurses or any other segment of the healthcare system, because usually we end up dealing with having to communicate the truth, sometimes the sad, uh, bad news. We have to deal with collusion. We often, it is us who have to deal with anger situation outside our OP, outside the ICU, in the ER. So many a times because we as doctors are natural leaders in the healthcare system. Though we grumble about the management people, taking those powers away from us, but all said and done, uh, our healthcare system is very different from like a factory or a business environment or hospitality industry, where people in the management system are the top bosses. In healthcare system, maybe they have some decisions on finances and policy, but when it comes to healthcare decision makers, we are natural leaders. So therefore we need to have those kind of skills to deal with situations in our clinical environment.
Thank you,
And
Doctor,
those
for the
things can
wonderful.
vary.
Thank you for the wonderful session. Actually, I believe in the beginning itself, we should tell the patient that this is the issue. Only not in the late. Actually, for example, for most of the patient with us, breathlessness is the issue. For us, it could be asthma, it could be COPD, it could be ILD. But the prognosis and natural history are entirely different for three conditions. So, in the beginning itself, we should have a talk with the patient. This is your issue. This is the expectations, like that. Many times it is not happening. That is the issue. Because, for example, ILD patient will go for like anything, and they will come with read some newspapers and the lung transplant, such and such things. But we should tell them what is the prognosis, what is the natural history.
Thank you. Exactly. So communication skills is a very, very major component. Now, unfortunately, Dr. Shahjahan, what happens is in our medical education system, the focus is on diagnostics
Yes.
and therapeutics. And this focus is in undergraduate level, postgraduate level, and subspecialty level, diagnostics and therapeutics. In undergraduate level, we learn a little bit of preventive aspects also, but by and large, it is diagnostics and therapeutics. There is no focus on communication skills, no focus on medical ethics, so and no focus on symptomatology. So symptomatology will help you, empower you to provide enough physical comfort to your patients, no matter what is the diagnosis or the stage of the disease. Medical ethics will help you, empower you to take decisions in complex medical conditions. Because then the decision that you take, if it is ethical, then you are safe legally also. So medical ethics is not taught, and communication skills is supposed to, as I said earlier, give you five things. It should save you time, energy, effort. It should get you better clinical outcome, and it should keep you safe. So none of this is taught to us, and we become doctors, and we are supposed to go out into the world not knowing how to negotiate these challenges. We may be very good in diagnostics and treating diseases, but the other components, unfortunately, and therefore, no wonder the relationship is worsening by the day, because what the community wants out of us is not exactly what we are providing to them. And we are not able to provide, not because we don't want to, because we are just not trained, we're just not empowered to do it. So we constantly do what we are good at it, that is diagnosing disease, treating disease, attending conferences, but we are very good at communicating with each other, the medical matter, and we appreciate each other, we applaud each other. But then the other important component is the patient and family and community at large. How are we communicating with them? So,
Thank you so much, sir. I think most of the questions that Dr. Deepti asked in her presentation was, I think that will be covered in the coming session. Can you have a quick look at those questions? Yes. So these were the questions that she has asked in her presentation.
I think the first, since we have put it up, the first question was how to
Yes.
convince a resistant patient to learn and practice in breathing technique. Probably we need to understand why the patient is resistant. Are the techniques too hard for the patient? Is it something that the person, or maybe sometimes when you tell some patients to do something and their experience of that, probably it increased their breathlessness, now they're scared of it. That could contribute to resistance. In my practice, I teach the family some, relaxing massages for the patient if they are having, especially dyspnea on exertion. Many times, patients in fairly advanced medical condition, be it ILD, COPD, CCF, or advanced malignancies, there because of cachexia. So they very easily get dyspneic on minimal exertion. Especially people are so scared of going to the bathroom because that trip is like a nightmare, like a hell for them. So people would rather have constipation than experience the breathlessness nightmare of visiting the bathroom. And many times people resist the idea of bedside commode or diaper and things like that. So I teach the family members some relaxing massages for dyspnea on exertion, and also maybe a little bit controversial, but a low dose of benzodiazepine, for example, sublingual lorazepam, 0.25 milligram or zero point 0.5, also helps with dyspnea on exertion. Uh, so subsedating doses of uh, short acting or medium acting uh, benzodiazepine. I choose lorazepam because it works sublingually, along with the relaxation massages that I teach the family member. So the patient just has to sit there and the family knows what to do. So when I teach the family, they have some task to do. So they stop panicking. So when you have an hand-eye coordination task for the family, so their focus is on that. So their mind gets diverted. So that also helps, because when the family panics, the patient is already panicking because of breathlessness. The anxiety and panic is highly infectious. So the patient's anxiety makes the family anxious, the patient's panic makes the family panic, and the family members' anxiety and panic increases the patient's anxiety and panic, thereby increasing the experience of breathlessness. So the massage the relieves the patient's anxiety because it is soothing. The task given to the family diverts their mind because they have something to do. So therefore, there also we cut down the anxiety triggers at both level. So that was something that I have to say. I don't know, Sridevi, you have anything to add to that?
No, sir. I was thinking maybe the fourth question can be taken like how not to lose our patience or temper and hope when counseling a non-receptive patient. It's a very interesting question.
Okay. As I said earlier, maybe a couple of things. One, when somebody, despite our best effort, is not receptive to our idea, maybe one we may not have yet won their trust. And we today in our session we talked about various techniques of creating a sense of empathy through our body language and verbal language. And probably that could be an issue that they may be non receptive because they have not yet started trusting us. They may be non receptive because they may have tried something and they may have found it not effective or maybe even more traumatic. But they may be finding it a little difficult to confide to us. And that could be one reason, or they may have some mental block, they may have some fear or belief system, something related to that, or they may have a financial blockade or a logistical blockade because of which they are non-receptive to our suggestions. It could be anything. So basically, again, it comes back to communication and trying to find out, trying to dig more information and trying to figure out why they are non-receptive. And last but not the least, it's also important to understand that we may mean well, but the patient has always the right to reject our suggestions, because after all, it is their body, their life, their right. They may come to seek our help, they may accept some part of our help, they may reject some other part of their help, or they may reject our help completely and go to some other place. All of that is their prerogative, their right, their choice. What we have with us is the satisfaction that we tried our best. That is all that is there in our hand. And that we should do. And if you have done that and we are convinced about it, then finish your day, go back to your family and forget about it and try to get a good sleep. Because in Sanskritam there's a shloka, karmaniya vadikaraste mafaleshu kadachana. So you do your karma, don't insist on getting the result, or don't insist on getting results in your favor, or don't insist on getting results the way you want it to be. Just do what is the best you can do for your patients and their families.
We can use
Long-winded answer, but I hope that suffices.
we can use someone else in the team also. Suppose our wavelength is not suitable to them, I think we can use someone else in our team also.
Absolutely. And I just said earlier, it's a team effort. It is not one person's burden. Sometimes the patient may have a better affinity for somebody else in your team. So if you are the HOD and the patient is more confiding to your junior doctor, don't have ego issues with that, and get the matter sorted out. That is what is important.
That's a very good answer to wind up today's session. I think we are more like a facilitator than giving them instructions on what to do. We just facilitate the conversation and help them to take the path they want. So in that way, we may not fail or we may not succeed. We are just facilitating conversations or take decision making. Thank you so much, sir. Dr. Deepti, there are a few other questions on advanced care planning and end of life care, and we have one whole session on end of life care and advanced care planning in this program. So I'm sure we'll be covering that, those two questions. And the last question on fentanyl, I think in last session by Dr. Miriam, and she specifically mentioned about sustained release morphine as
Morphine, yes,
the drug
yes.
of choice for breathlessness, not even immediate release. So she was insisting on the
Sustained release.
sustained
Yes.
release. Yeah, that's something I would comment on the last. Thank you so much, sir, for your wonderful session, and we'll be looking forward to the next part of communication, more complicated conversations. Thank you so much, all the participants, for being with us and your interactions. See you next week with the continuation of communication session.